Good morning. Assalamu alaikum. Thank you very much for Gulf Financial Society for inviting me for presenting my case over here. I have nothing to disclose because my case is basically a perforation sealing case, and I use it a fat, and nobody is interested in fat. Nobody will invest in fat. So fat is hit everywhere, even in the human body, but we have took advantages and we have used it properly and correctly. So this is a history of a 55-year-old gentleman who presented with angina class 3. He's hypertensive and diabetic. He's a non-smoker and he is symptomatic despite optical guideline directed medical therapy. So this is this first chart, and the left system was okay. There was nothing on the left side. So there was a lesion in the mid. For the sake of presentation, so I make the slide in less than number. So we put a stent in the middle, and there is a balloon dissection in the proximal portion of the RCA. So we stunted the proximal portion as well, overlapping with the distal stent. And then later on, we saw this happen to the patient. So there is a perforation in the PLV branch in the distal area. Actually, we used a works wire BMW, and this case was actually done by our training fellow. So we immediately recognize this happening, this complication, and it is very important and imperative that we should go and treat it there and then, because these are the patients, if you left or overlooked, they will present later on, and you will be called in the middle of the night that your fellow will call you for that. So this patient is hypotensive, he's sweaty, he is tachycardic. So you are wondering whether it is a retrograde peritoneal hematoma or it is a perforation or stent thrombosis. So it is very important to recognize this complication at the first site and treat it there and then. So So we went and checked our inventory for the coil, of course, and unfortunately we were run out of micro coils to embolize this distal perforation. So next, what to do? So as we went from the femoral approach, so we took a fat from the femoral area, and we took a micro catheter and we embolized the fat distally. This is the fat which we took from the patient femoral area, and it is very difficult to load this fat in the micro catheter. So you have to try again and again, and there is a technique. So you have to fill the syringe, load the fat in the syringe, and you keep the syringe upside because the fat is lower in density, so it will flow up, and you have to poke your micro catheter down like this. So you cannot inject. If you go inject like this, the fat will go to the plunger side. So you have to keep it like this, and then you have to inject the fat to load the fat in your micro catheter. And you have to attempt again and again. It's not easy to load fat in this case. So this is you can see the tip of the micro catheter. This is a fine cross micro catheter which we took, and we just take this micro catheter to that area. Cannot go distally because we were afraid that we may do further damage. So this is the area from where we are going to embolize. We tried, and in the first attempt we were failed. There was still some perforation, and then we did it again, and this time we were successful for fat embolization in this case. The total time it took about 45 to 1 hour, and this was the last shot. That was the last shot previously. So the post-leg PCI is very important. What should you do and what should you look for? So you should look at your stent, look at the distal edge, whether there is any subtle amount of perforation or not, or void-induced perforation is there or not. You look for dissection, and you should look at whether you have done any side branch occlusion or not. Then you look at the distal area, and look for perforation or embolization. And you have to take two different pictures in different views, and you have to make your cine prolong and prolong injection. Because the distal perforation is not visualized in the first instant. Sometime in the later frames, you will recognize that there is a distal perforation. So what is the algorithm for coronary perforation? So you have to inflate the balloon and occlude the blood flow in the affected vessel. If there is hypotensive, patient is hypotensive, you have to push IV fluid or pressure. And it is very important, you have to notify the surgeon for your help. And if the patient is hypotensive, tachycardic, of course, you have to do cardiocentesis and autotransfusion as well. So sealing a distal vessel perforation, it is important. Different options are there. Fat, coils, these are the #1 options for distal vessel perforation sealing. Then you can do aspiration through the microcatheter, but usually it is not successful. You can make your own thrombus and then inject in the vessel. Microbeads are not available, thrombin is not available. So what are the advantages and disadvantages of fat versus coil? The visibility in the fat is very poor, so cannot visualize where you're going to embolize. So you have to rely solely on your injection. But before injecting or loading the fat into the microcatheter, you can inject small amount of the contrast into the fat. So when you go, it will be visualized on your screen. So this is very important. Of course, coil is done with the controlled delivery system, and catheter, usually you can inject the load, the microcatheter with any microcatheter, but when you are to embolize, of course, you need a large microcatheter like ProGrade. It is universally available, cost is 0, and the sealing it with the fat is immediate. While with the coil, it takes some time because the polymer will take some time to swell up and occlude the vessel. So it takes some time. There are two types of these micro coils. One is the axiom and another was the azure. For different, you have to use different size of the microcatheter. So the lesson is that tamponade can happen our post-distal vessel perforation. Thus, treat it there and then. Thank you very much.